Hi, my name is Chris Bentley. I'm a doctor and my role has been very much concerned with public health since I re-emerged from a long period in Somalia in the 1980s. I've retrained in England and then had a number of public health director roles, including in Sheffield and South Yorkshire. Most recently, however, I've been working for the Department of Health over the last 5 or 6 year period, where I was the head of a thing called the Health Inequalities National Support Team. And this was a really interesting role where we got to track around the 70 most deprived areas in the country with the poorest health, looking at how to try and improve their health inequalities issue and how to narrow the gap between those 70 or 80 areas and the national average. So it's a very challenging target, but enabled us to learn an awful lot over those 5 years of a lot of very good practice, but also a lot about the gaps and barriers that everyone was experiencing in trying to make things move in the right direction. We put together a set of the most important ways we felt that we could influence the inequalities agenda, and a lot of that was about trying to get into contact with people who have the minimal contact of good quality input that might help them to improve their own health. And we came up with a range of ways of doing that. We based ourselves on the Aitchison definition of public health, which was about improving health through the organised efforts of society. And so we were looking at different ways that we could harness all the different organised efforts of society to try and really make it a sustained difference at the level of the population. Now, actually working with frontline staff in the statutory public sector is a terrific way of starting on that, really. You could call it low-hanging fruit, because we should have direct control over what our staff do in the health service, in the social services, in other local government services. And so it seems stupid not to try and harness every contact with that public health service, public sector service, in the interests of trying to help people to improve their own health. And so we independently, if you like, started to work on how you'd bring system and scale to that program. You see lots of nice little projects, but how do you bring system and scale to it so that you stand a chance of making a percentage difference at population level?
Yes, of course.
And so we were pursuing that line, but I knew from the past, I knew that Karen Payne and others involved in the project, a program of making every contact count, had been really interested in how to extend the education to make public health a wider, engaging issue, and trying to do that in a more systematic way. We kind of crossed paths in relation to, oh wait a minute, well look at it, pushing on the same doors here. So the very systematic way that the MECC programme was looking at how do we harness that frontline staff, how do we actually bring them on board to make a difference, was exactly what we were after as well. Industrially, scaling it is exactly what we were pushing on, and again, this is one of these synergies with MECC, because it's not just a question of it's patchiness is the enemy as far as I'm concerned. And as I say, you see little projects, and in a way, what you find is organisations use little projects to get out of jail free. They can point at it and get people to stand up and talk about the little successes that they've had. And people all say, oh, that's good, and they move on, not realising that actually 95% of the hospital or whatever it is isn't engaged at all. The other thing, of course, is patchiness in time, because you do a project, you train up a cadre of staff, and before you know it, some of them have moved on, you've had new people moving on who didn't get the train, etc., and the whole thing's kind of dissipated. So it's a question really of how you get that sustainability into the whole thing, as well as the spread.
Yeah.
And you know, I mean, we found when I was working in Sheffield, we were looking at how, tobacco control and that sort of thing, particularly. And we had some nice little projects working in different parts of the hospital, but we came across this champion consultant who was a vascular surgeon.
Yep.
He was absolutely rabid about smoking,
right,
and getting people to stop smoking.
Yep.
And so we harnessed him and got him talking on the Sheffield Star and all that sort of thing about it all. But we thought, oh, let's just track down and see all the people that he's getting through into smoking cessation services with his kind of efforts. Zero. Absolutely no referrals from his part of the hospital into the system. And the reason, you know, in a way, was that when he'd had a go at a patient and really said, look, if you want to protect your health and your legs and your whatever, you've got to give up smoking. And they walk out of the room with a little card, and sure enough, very little happens.
Nobody would follow.
Whereas if he wanted them to go and have some physio or get a scan done or something, he'd write out a form, give it to them, and the receptionist would channel them down the corridor, and there they'd be. So it's a question really of how do you actually get the spread right across the hospital, not just little bits. And the mechanisms for doing that go quite far back into organisations and hopefully into partnerships. The way we worked it through in the inequalities team was we basically said, what are the main principles of trying to get it systematic and more scaled up? And we came up with 4 things. The first one was to get frontline staff trained in basically screening and then the basic conversations. And that, as you quite rightly say, that shouldn't be just a one-off, but actually lots of refresher training and then getting people to rethink it and have another opportunities, etc., to talk it all through and that sort of thing. That was the number one. Second one was to have some people in each area that have what we call brief intervention training that can take it that next stage, and they can actually talk people through when they've identified a problem that really people want to do something about, to take them on that next stage. The third thing was to have some kind of referral pattern, so that when that's been achieved or that's been done, how do you put people in contact with specialist people who can really help them through, the smoking cessation staff or the alcohol counselling people or whatever it is, and not just have a sort of, again, a little card that you stick into their hands, but have proper referral pathways that work from where you are. And then the fourth thing is to count it. And count the referrals that are going through that process, because then you can work out which parts of the system are and aren't functioning, and then focus down in on them to give them the support to actually get them up. So we ran with that for one. It stood the test of time. We thought we still think those are good principles. But then we added a fifth one, partly working with Meg, and that was about get the staff to do it for their own sake first. It's just what you were implying. That if you can actually take the staff through the programme where we show them about the problems with alcohol or nutrition and how to lose weight and all that sort of stuff, we do it for their own sake and their family's sake, they will be so much more convincing as advocates when they're talking to the public. And so I think that was a lovely fifth principle that we added that did exactly that. I think it enriched it. The future forum that was asked by the government to look into important factors and bring in clinicians and managers into the discussion to actually advise the government on these things. One of the 4 big areas they chose to talk about was public health in the NHS. And they produced a document at the end of last year, and the government then produced a response to that document. In that section, the first section that they put in there is making every contact count. And they really reinforce how important they think this is. And then they actually put a kind of 5 layers of how they want to make it happen, which I think are really good. The first one is to make it something that we expect our frontline staff to do. And they're actually even talking about changing the NHS constitution, consultation later this year, but suggesting that they change the constitution to make it a duty of staff to actually do this.
Good.
Second one is to actually then get managers to reinforce that
Yep.
by actually including it in appraisal systems and so on, so that we're making it systematic
Yep.
from a manager, this is what we expect of you kind of role, and incentivising.
Of course.
The third way is to actually then get employers to back the issue. And recognise that they'll need to bring in other skills to be able to achieve it, and therefore they talk about partnerships with important groups. So
Yep.
they're saying providers need to have partnerships with public health, with health and wellbeing boards, with education and learning institutions,
Yep.
and so on. Then they say, and they need to be supported by a sort of unholy trinity of Public Health England, Health Education England, and the NHS Commissioning Board.
Yep.
And they're saying the Department of Health should support an alliance that actually got them to consider how they can together support a making every contact count approach. And then there's a final one, is the NHS Leadership Academy,
Yep.
and they're actually talking about getting leadership involved in this,
Yep.
and actually including specifically making every contact count as part of a leadership programme through the NHS to drive it. I mean, wow, that's a very powerful
Yeah.
5-layer way of introducing it, and it makes it systematic and scaled
Yeah.
up. I think that mission that I was just laying out, that the government sort of framed for us,
Yeah.
saying this is what it's going to take a while to come together. We haven't even got Health Education England yet, and it's going to be thinking of lots of other things before it gets down to that sort of content.
Yes, of
You know,
course.
the consultation on the NHS Constitution, that'll take a little while to
Yes.
filter through. So it's going to be quite a while where, if we're not careful, take the eye off the ball. In the meantime, MECC can be really working with organisations. Now with this backing, this is our direction of travel.
Yes.
This is the vision. Now we're beyond the vision. We know how to make this work.
Yep.
So they can actually really start working with people to make it happen, make it deliver. Because that's, again, something we saw in the Health Inequalities team. You know, the amount of flipping marvellous documents that we saw that laid out everything you would expect to see in there. There was a kind of word bingo
Yes.
in there, you know, where you could check off all the
Yeah,
key
yeah.
words and phrases throughout the document. But actually, none of them really said, what are we actually going to do to move from here, where we're in,
Yes.
in a bit of an unsatisfactory situation, to over there, where our aims are
Yeah.
pitching us. And that's where MECC, I think, has got that practical understanding and knowledge and track record that it can actually guide people through that. So I think I'd like to see MECC itself expanding a bit, you know, getting a bit more industrially scaled to be able to kind of help and support people to do this.
Yeah.
I think there's another opportunity we've missed. I mean, you mentioned the outcomes framework, which is going to be really important. But when I was talking at this at an MECC meeting last year, there's another component in what's coming through, and that's within the NHS bill. At the moment, we don't know how that's going to look
Of
at
course.
the end, but at the moment, it actually puts a duty on various levels, Secretary of State and clinical commissioning groups, to address inequalities in access and outcome.
Yeah.
And that's a huge thing. And it's the first time that doing that has been a legal requirement. Now, the way I sort of explained it last year was access is every contact.
Exactly.
Access is every contact.
Contact, yeah.
And outcome is making it count.
Yeah.
So as far as I can see, if we can actually follow through on the bill, with the bill behind us,
Yeah.
then making every contact count will achieve access and outcome for us. And you know, that's what the service is going to have to do, because it'll be a legal requirement. And having making every contact count programme there to actually be the ones that can really support delivery, I think would be tremendous.